Hello, everybody. Good afternoon, good evening, maybe some good mornings as well in our group today. Thank you so much for joining us. My name is Carmen Valle, and I am the IFRC co-chair of the IASC MHPSS Reference Group. I am going to be your host today, and I'm going to guide through this session. And I'm really glad that we are being joined by so many wonderful colleagues from all over the world. It's good to read some of the very well-known names. Welcome to this session, which we hope is going to be very informative and let everybody know what is it that we've been doing from the reference group on this pandemic, on this COVID-19 pandemic, to support the mental health and psychosocial support of the communities affected. I am really glad to be joined today by a number of wonderful colleagues. The first one that I would like to introduce is my dear colleague at the reference group, Dr. Fahmi Hanna, who is the technical officer at the Department of Mental Health WHO in the headquarters in Geneva, and he's the co-chair of the reference group on the side of WHO, and I'm really glad to have you here, Fahmi.
Thank you, Carmen.
Thank you, welcome. We wanted to have a session that really talks about the response on MHPSS response to COVID from what is happening, from the countries where the response is being more necessary and more important. So we invited a couple of our dear colleagues in technical working groups, mental health and psychosocial support working groups at country level. And we are really, really happy to have with us Deborah Magdalena, who is the working group coordinator for mental health and psychosocial support in Nigeria. Deborah, really great to have you with us today.
Thank you so much, Carmen, and great to be here. Thank you so much.
Thank you. We also have Adib Asrori, who is the also MHPSS or Mental Health and Psychosocial Support Program Specialist at UNFPA in Myanmar, and he is also co-chairing the MHPSS Working Group in Myanmar. Welcome, Adib, and thank you for joining us. And finally, thank you, Adib. Finally, we also have Nikos Ionakis, who's a scientist director of Babel Daycare, one of the organizations who is responding to the refugee crisis in Greece, and he's also coordinating the MHPSS response there in the country. Nikos, thank you for joining us and welcome as well.
Hello, thank you for the invitation. Thank you for letting me be here with you.
Thank you for joining us. Good background. And welcome everybody else. We are going to try to really stick to time. We had a wonderful session on Monday, and unfortunately we didn't have time to respond to some of the really relevant questions on the chat. So today we're going to try to be very on time, and we're going to start assuming that not all of the audience is aware of what is the Mental Health and Psychosocial Support Reference Group. We're going to just go over a very brief presentation to explain what is it that we do from the reference group. My colleague Fahmi and I are just going to explain a little bit. I would like to go to the first slide, please. Thank you. The Mental Health and Psychosocial Support Reference Group is one of the associated entities of the Interagency Standing Committee. And from the reference group, we are providing the overall technical guidelines, standards, and bringing together a good number of organizations from all over the world who are contributing to mental health and psychosocial support. The many things that we do are related to providing this overall understanding of how do we all do mental health and psychosocial support, starting with the name itself, with keeping together MH and PSS, because we truly believe, and we know by the evidence, that we need to consider the entire response from the most severe mental health needs to the psychosocial well-being of the whole community affected by crisis. We also have, during the years, developed even very detailed resources on how we can respond, how organizations can respond in mental health and psychosocial support at very different levels, from the community level all the way into the specialized services. And this work of many years has allowed us to write a good number of guidelines and guidance for the field, starting with ourselves, the very famous for us guidelines on MHPSS, but also some guidelines for other actors, other clusters, other sectors, and also for specific situations and settings like Ebola response guidelines and other more specific details. Next, please. When I talk about the reference group, and of course you have with you today ourselves, the co-chairs at the moment, Fahmi and myself, but this is not the reference group. The reference group is actually the joint force of all of those members who daily contribute the work to this joint effort that is the MHPSS reference group. At the moment, we have 60 full members with 11 observers and 10 donor organizations. And all of this structure, all of these members together with the co-chairs are allowing us to really connect the work that is happening at country level, which is the most important. This is what we work for, is to make sure that the responses at country level are efficient and they're good for those communities that need it. That is really well connected then with the global level. And we serve at this structure that can connect both, organize both, coordinate both, and provide guidelines. Over to you, Fahmi.
Thanks, Carmen, and I hope you can hear me because my connection is a bit unstable. Thank you. So, colleagues, one of the questions we commonly get is where or how mental health and psychosocial support should be coordinated within public health emergencies. And the answer is simple. The guidelines, the IASC mental health and psychosocial support guidelines told us, as well as the IASC principles in the joint inter-agency call for action and many guidance that came through the IASC, that mental health and psychosocial support is cross-cutting topic within humanitarian emergencies, of relevance within the health sector, within protection sector, within CPOR, GBVOR, education, camp management and coordination, nutrition, and other sectors as well. It's a cross-cutting topic where in good humanitarian practices, activities will be implemented in all these sectors and clusters, but within one single mental health and psychosocial support technical working group where focal points from all these sectors working on mental health and psychosocial support would come together in the technical working group. Colleagues, the same model apply to public health emergencies. In public health emergencies, as indicated by the Strategic Preparedness and Response Plan for COVID from the World Health Organization, and in many of the IASC guidance we developed, the cross-cutting. It is of relevance to partners coordination, such as the MHPSS technical working groups. It is of relevance to risk communication, such as stress coping messages to communities, case management, such as case management of mental manifestations for people with COVID and people with Ebola and people with Zika, and to operations, such as the mental health and psychosocial aspects related to duty of care of health workers, for example. So mental health and psychosocial support is cross-cutting in humanitarian emergencies and in public health emergencies, such as in COVID-19 and in Ebola. But let me take you through few points, the highlights, because the year of COVID-19 was an unusual year for mental health and psychosocial support, and COVID-19 also came at very unusual time for mental health and psychosocial support. We knew from the beginning that there would be a huge impact on mental health and psychosocial needs because there were similar emergencies and outbreaks before where there were remarkable impacts on mental health and psychosocial support. So first step, we looked through desk reviews on how the reference group has responded to previous public health emergencies. We had from our predecessors documents that worked on the H1N1 influenza outbreak and mental health and psychosocial aspect. We had guidance before from the reference group on the Ebola outbreak, on the Zika outbreak. So we looked at all these documents and started global coordination calls as early as January, when at that time there were only cases in China and only cases in Thailand, and start to document and coordinate from all the reference group member agencies. We start to have also global call for country level technical working group chairs, which continued. And also it was a year where for the very first time, mental health and psychosocial support was mentioned in the global humanitarian overview. Yes, that's true. The very first time it was 2020, and the second time was 2021, where mental health and psychosocial support was included in the GHO. Mental health and psychosocial support was also included as a cross-cutting issue by the IASC principals, reaffirmed in December 2019 and emphasized again in the joint interagency call for action. That helped really our work during the COVID-19 response. Mental health and psychosocial support came in many high-level meetings and global coordination and networking events, such as the HNPW. Last year, in fact, was one of the first times where we had mental health and psychosocial support, and this year is the second time in ECOSOC Humanitarian Affairs segment as a side event during the UN General Assembly in the Global Refugee Forum, so that bring mental health at the forefront of the policy discussions in humanitarian fields. Also, in 2020, we launched it for the first time through support from the Dutch standby partner, DSS. We launched a rapid interagency deployment mechanism for mental health and psychosocial coordinators with 17 successful deployments during 2020. And this come really matching with the increase in need because the number of country-level mental health and psychosocial technical working groups increased during COVID-19 from 22 countries to 53 countries having such coordination mechanism. So the match between really the demand and the supply provided through the surge was key. Colleagues, one of the key achievements also we consider during COVID-19 is developing of interagency tools for mental health and psychosocial support related to COVID-19 and across many age groups. From tools to children aged 6 to 11, such as this children's storybook, to tools accompanying this resource for their parents and teacher, to guidance for agencies such as the interim briefing note, which include recommended activities that really influences the response in many countries, to guidance to older adults, to guidance also to frontline responders on integrating basic psychosocial skills, as well as guidance on adapting operations to mental health and psychosocial needs during the COVID-19 for different sectors. Other achievements, colleague, was inclusion of mental health and psychosocial support in the Global Humanitarian Response Plan. Again, first HRP, which had mental health and psychosocial support, came during COVID-19. The United Nations Secretary General included in his policy brief on COVID-19 and mental health and psychosocial aspects, including the role of the IASC Reference Group and some of its products, which really facilitated the impact and uptake by countries of such tools and such concept as mental health and psychosocial support. We see that reflected when WHO assessed between June and August last year, and we found that 89% of all countries, not only humanitarian settings, but it expanded also to countries in development settings, mental health and psychosocial support was included in 89% of countries' COVID-19 response plan. In the Global Humanitarian Response Plan, in the WHO Strategic Preparedness and Response Plan for COVID, and in the UNDP COVID-19 Framework for Response Framework, we found mental health and psychosocial support indicators included for the first time in multilateral plans. And finally, the World Health Assembly in 2 weeks' time, discussing the WHO Executive Board, the governing body of WHO, the member states are discussing the first ever decision on mental health as an integral component of all public health emergencies by all the countries of the World Health Organization. I hand over to Carmen here.
Thank you so much. And indeed, it's been a busy time. Fahmi was mentioning the capacity that we've developed to deploy colleagues to country level responses. This has been really important for us during the context, in the context of COVID-19 last year. We had the opportunity to respond rapidly through these search support mechanisms through the DSS, through the Dutch search support, to requests from 15 countries actually, and some of those deployments actually were also expanded. So having had the opportunity to establish this mechanism, we didn't know at the time when we were developing the COVID will happen. So the search mechanism was something to be developed anyhow, but then it came right on time for responding to these many requests from country level. And this is a mechanism that is allowing us to respond to requests from country level, to send colleagues, experts on MHPSS that can contribute to the country level interagency work. So bringing together the coordination elements, training, evaluations, and so on, that might be not possible to cover at the moment with the resources available in the country. There's more information that we can share on this search mechanism. We'll share the link on the chat. Next, please. We didn't only support our colleagues through this mechanism, as Hami was mentioning, we also created a lot of resources. Some of them came very, very early in the response and were extremely powerful in allowing colleagues from all over the world, in those many more than before technical working groups established, to respond to COVID-19 and the mental health needs. One of the examples that I wanted to mention is the operational considerations, because this document allowed us to give very specific advice and guidelines on how to introduce the MHPSS needs across multiple sectors for colleagues on other areas of responsibility, and also depending on what level of COVID-19 response was necessary. From countries with no cases that will be just preparing themselves, to countries with severe levels of transmissions. That was a guideline very widely used, and it continues to be used and translated to several languages. Next, please. Another one that I like to share is, as you can see, that the reference group has been working in very technical, very hands-on the job for professionals types of documents, but also tools and toolkits, guidelines, documents that can be used by the respondents themselves, by the community, by children, like Fahmi was mentioning and will continue to mention in a minute. One of these toolkits is Living with the Times. This is the first document that we have developed targeting very specifically older adults, which we all know have been severely affected by this pandemic. The beauty of this toolkit and a way of working that we've found incredibly useful over and over again with many of our resources is through very in-depth consultation. These are not products that we decide the content and then developed. These are products that get developed after very extensive consultation, in this case with older adults from 60 to 90-year-old in more than 50 countries, including humanitarian settings. So we consulted with them. We listened from them, what is it that they needed in terms of mental health and psychosocial needs. And the outcome is this very friendly user, very beautiful, as you can see, toolkit that allows to address their concerns on mental health and psychosocial support. Another one, next please, is one of the very important first, quickly at the beginning, needs that were identified was the capacity of any responder, not mental health or not even health responders, but everybody responded to the pandemic, from nurses to doctors, but of course also those delivering food, those taking care of specific services, even our colleagues in the police and in all sectors. This is a very stressful response for the person responding and for those receiving care. So we wanted to go beyond psychological first aid, and we created this basic psychosocial skills guide that allows anybody responding to COVID to be able to take care of the mental health and well-being of the community affected. Again, very importantly, that this was done after extreme consultation with survivors, with emergency responders, and throughout several countries and humanitarian emergencies. Over to you, Fahmi.
Thank you so much, Carmen. And colleagues, one of our resources where during COVID-19, where the uptake was really remarkable, was a children's storybook designed for children 6 to 11. And we originally designed it by having a survey disseminated globally. In the first week, we had responses from more than 100 countries, 1,700 children, their families, and their teachers. And based on their inputs about stressors and their coping with COVID-19 related stressors last year, we adapted this children's storybook, which basically tells children how to deal with emotions, with stressors, with grief during loss of loved ones, with new atmosphere at school, with issues related to stigma of other children or other family members having COVID-19, and developed the My Hero Is You children's storybook on COVID-19. We released it in 6 languages, but the uptake from the field was remarkable. The countries translated it in 238 languages, making this resource, in fact, one of the most translated children's storybooks in history, and one of the most translated resources ever released by the United Nations, including also, in addition to translations, more than 50 multimedia adaptations, from puppet play to theater plays to video animation to audio version to sign language video version, more than 50 multimedia animation. And the symphony of collaboration across global actors for translation and adaptation you see in the statistics here, it's almost equal. UN organizations, universities, international NGOs, professional associations, as well as different government sectors, all contributed to the translation and creative adaptations of this resource. I give you the example here. You have around 10 languages from India alone. You have the similar equal number from local languages in Uganda, like 61 languages spoken in humanitarian settings, 111 languages in low and middle income countries. So really remarkable statistics. And sometimes colleagues ask us, do you know about the impacts? How many downloaded it? And these are examples for the figure of downloads. We didn't count it for all the languages or all the adaptations, but some here seen 2.4 million times, Korean version 200,000 views for their video adaptation, the Spanish audio reading 17,000, and remarkable also what volunteer, what grassroots organizations in countries was able to adapt. I mean, the Zimbabwean Blind Mothers Foundation is the one who adapted it to Braille, and that was one of the first inclusive or accessible versions that we got. But also sign languages, we got it in 4 different sign languages, from Korean to Indonesian, many read alouds and many audio files for children with sensory impairment as well. In the first 6 months, only the English version was downloaded more than 350,000 times, only from one of the links. We see many smiles around the world from different geographical locations for boys and girls of this age group from different countries who are reading this book or its adaptations. And I'm going to end here with this very interesting map. We tried to map the languages that countries would report as their official languages, and we mapped in orange color where the storybook is available in the country official language. So we still have some countries where only there is partial coverage of official languages, but the story has traveled really with its imaginary character to support children around the world. We are working on a new 2021 with all our partners version of the same book. Thank you.
Thank you so much, Fahmi, and we hope this was a very brief, we could talk for hours, but it's a good overview. And Sarah, thank you so much for sharing the links online where you can access all of these resources. But of course, all of this work is only meaningful and important if it's useful to the field. And many contexts, many humanitarian contexts that were already in suffering extreme circumstances, trying to work on MHPSS with very difficulties. They already were facing these difficulties when COVID was added. So we wanted to really create resources that will be useful for the field. And our colleagues with us today can tell us a little bit more about how these resources have been used and adapted to their context. And I would like to start with Nikos, if you would maybe share with us how the response has been for the refugee response in Greece and how these resources have been of use for you. What's the work that you've been doing in country? Thank you.
Yeah, thank you very much, Carmen, for this invitation. What I can say is that MHPSS has been a priority, has been set as a priority quite since the outbreak of the pandemic last year. And to show how it was set as a priority, I think it's enough to say that the Ministry of Health, the Greek Ministry of Health, supported the initiative that was taken by the first psychiatric clinic of the University of Athens, together with the Federation Argo, that matches organizations working in the field of mental health and psychosocial support, psychosocial rehabilitation, as well as other organizations, to run a helpline, a phone helpline for all people, either people who were lay people or professionals working in the first line and so on. And this helpline is still on and is offering its services, and it's not only psychosocial, psychological support, let's say, but also social support, connecting, linking needs to resources available, and so on. And this is something that shows that it has been a priority since the very beginning. From the other hand, for us, it was very important to have access to reliable information and to reliable training resources to be able to support colleagues working in this, in the support of others, to meet the challenges that were introduced by the pandemic, and especially, or the syndemic, as I prefer to call it, and especially those that are particular to this pandemic. For example, that we had to work remotely. And this was a very big challenge for all of us, since it was very difficult. So we had to think how we should do such things. And the tools that were developed by the reference group, IASC MHPSS Reference Group, were very useful in this. What we did as MHPSS Technical Working Group of Attica in Athens, where I work, was to translate and disseminate tools such as the interim briefing note addressing mental health and psychosocial aspects of COVID-19 outbreak, the basic psychosocial skills, as well as the guidance on operational considerations for multisectoral MHPSS programming. From the other hand, the University of Athens, again, the Child Mental Health Department of the University of Athens translated the My Hero is You, but translating it as My Heroine, female hero, is you. And the good thing was that it was adopted, this edition was adopted by a high circulation newspaper, and they printed it, and they disseminated throughout Greece together with the newspaper, so that it could reach all, the whole country. Another sector in which the materials and the tools were very useful were in training, especially BPS, the basic psychosocial skills, that we combined. We set up trainings in which we combined all tools plus PFA, psychological first aid. And we facilitated trainings focused on either on specific professional figures like nurses or social workers in collaboration with the relevant national associations. We focused on workers in specific fields or sectors. For example, workers who work with homeless people, workers who work in refugee camps, and so on. Then we focused on professionals who were hired by associations through a program funded by the Ministry of Health, the Greek Ministry of Health, to support specifically people who were affected by the pandemic, either because they were infected or their relatives or professionals working in the front line. So I think that we had the possibility to do all this because we had a very strong background offered by these tools, and it was really useful because in such times it's good to feel that we have we can feel supported as in order to support others. And the tools had mainly this role. Thank you very much.
Thank you so much, Nikos. And once more, I've said this before, but once more, congratulations on the great work being done. It's definitely a very complex situation, and we're really glad that the resources have been useful. So Thank you so much for that hard work.
Just to say that now these days we are working on the translation of the Living with the Times. I hope that by the first days of May it will be ready.
Brilliant. That's excellent news. Thank you so much, Nikos. And of course, the Greek context is one very specific context. That there's others that we would like to listen to. Each humanitarian response has its nuances and its complications. We are joined today, as I was saying at the beginning in the presentations, by our colleague Deborah, who's been coordinating the technical working group in Nigeria for quite some time now, and she's also been very active. Her group has been very active in translating and adapting and using these resources. Deborah, over to you to hear how this COVID response has been in Nigeria and how you've managed to work with the resources.
Carmen, yeah, and really great as well to be here and also to listen what Nick was already share, of course. So I can also relate on some of the experiences that Nikos already share in experiences in Greece. So for the Northeast Nigeria, what I can share, because when we share about the concern faced in Nigeria, maybe I can go into like prior to the COVID-19, we already faced the humanitarian crisis, especially in the northeast part of Nigeria, which is the insurgency of the Boko Haram for the past 10 years. So this is affected and giving a sufferings for millions of Nigerians, and also affected the living condition, and also where people are living in 140 IDP camps and in many host communities. So in this kind of like complex settings, we already have like a challenging condition, and the COVID-19 is actually increasing the psychological distress among the affected population. There's fear, anxiety, confusion, frustration. I think this is mainly on, although the other countries' experiences, but it's adding on the how it's already existing all these problems, and also we have, as we already maybe aware, on the high level of stigmatization at that period of time. So it has a really major impacts on the overall living standard, on physical and also psychological well-being of the IDPs, and also those who's living in the host communities. So what I can share about the COVID-19, so it also has bring huge impacts on, we say it about the negative aspect, but also how actually the mental health and psychosocial support approach is actually evolving and adapting to the needs of the population, and how the partners, especially under the MHPSS working group in Northeast Nigeria, that they have to change their program and how to prioritizing on the remote support, remote counseling services, peer-to-peer support for people living in the same household. Although I think what Dr. Fahmi already mentioned as well, the utmost priority is the safety and the well-being of the staff and volunteer who actually carrying out the intervention that might also have a really high risk. So that was actually the changing that that happened. But of course, when we say the changing, it's not like us and an idea. So now I want to link it to the tools that were developed by the IASC Reference Group on the MHPSS in emergency setting, and also as Dr. Fahmi and Carmen already shared early. I can maybe focus on the two documents or two publications that really have a huge impacts on the MHPSS partner in Northeast Nigeria. So first is about the interim briefing notes that I can say it was published in a very critical time, where MHPSS partners in the country level need a guide of what to do. We know, maybe flashback to the March 2020, when there was a confusion in the beginning on how to adapt the program and the activities. And also in the addition, there's like also challenging regulation from the state government, you know, the lockdown, and then like ease the lockdown and everything. So it was adding like all this confusion. So those publication is very critical to us, and also it's very useful. It was disseminated to the MHPSS partners. It was very useful as a reference, and also as a providing the ideas on what to prioritize. So the MHPSS working group contributed the information using the tools on this interim briefing notes to the Borno State Ministry of Health on the COVID-19 preparedness and response plan. And also there's another documents on how like COVID-19 preparedness and response priorities for the ongoing humanitarian situation in North Nigeria. There's also contribution to the multi-sectoral response strategy on COVID-19 in the Northeast and other documents. So it's really helped when the other health sector or even in other government was asking, okay, on MHPSS, what we can do, we can share what is the priority based on the guidance that was given in the beginning. So MHPSS partner mainly adjusting their project proposal and MHPSS activities, and at the national level, at that period, the MHPSS is included in the one of the chapter on management of complication on COVID-19 in the national interim guidelines for clinical management of COVID-19 in the version on June 2020. It was not there in the first and the second version of the guidelines. So we see like how is this impact given to not only the local within the Northeast, but also in the national level in the Northeast Nigeria. In the Nigeria. The second one publication that I can share is maybe about the My Hero issue. Dr. Femi already mentioning and giving all the dashboard, which is really, really great. For Nigeria, we are working together with the Translator Without Borders, and it was translated into 9 local languages. It's not only selecting 9, it was selected based on the assessment language, which is the primary language spoken by the Northeast people in Nigeria. So it was in the beginning, we don't really expected that it will be like really huge number of the local languages, but the support from the other partners, which is the TWB at that time, it was really appreciated. And as Dr. Fami already shared, it was not only available in the documents on the PDF file, but also in audio file that we've been like really supported by them. So it was really appreciated by partners. Again, when people need like a support, when people need the guidance, when people need reference, especially on the MHPSS partners, we have the resources that really, really helpful. I think this is what I can share from my end. Thank you so much, Carmen. Over to you.
Thank you so much, Deborah. And I can again only congratulate the work of the technical working group in the country. I think it's amazing to see this this double contribution. And I would maybe share briefly that when we produce these resources, of course, there's a big group of organizations working on them together. We share with country level. The country give us very relevant feedback and adaptation. And it's a process of back and forward that also is allowing, like you were mentioning, this advocacy at country level, this using these resources to continue advocating for changes and for more MHPSS integration. So big congratulations and thank you for sharing and spending some time with us today. I might get back to you later, but we would like to go a little bit east now, and I would like to welcome once more our colleague Adip from Myanmar, who is joining us today to Adip, maybe hear as well how you've been very active in the technical working group in country, in adapting, in translating. You find yourselves right now in a very complex situation as well, and we're really grateful that you can join us and give us a bit of information from your side.
Yeah, thank you so much, Dr. Carmen. If I may share a quick presentation. Yeah, I hope that everyone is able to see my screen.
We can see it, yes.
Yeah, so just quick, yes, thank you so much, Dr. Carmen. Just quickly share some the COVID-19 response and development result from Interagency Systemic Committee Reference Group that we have been using in Myanmar. So here, like this will be related with the one that I would like to mention about the BPS, basic psychosocial skills. So before COVID, actually the situation is like as also some of the presenters mentioned before, like Deborah, like there is a high demand of MSPSS need, but we have limited mental health professional in a country. We only even have 4 psychologists in a country, then mostly they are graduated from outside the country, and MSPSS service is still based on the institutional base. We still have not much community-based MSPSS here, and we still have no legal framework in terms of MSPSS. So it is easy here in someone to claim themselves as mental health professional without any proper certification training. So, and how COVID-19 affected ongoing response. Some of the same with the other countries, we start to having this kind of MSPSS remote services. They shifted into remote modality, and some organizations also conducted some quick survey in order to understand better the community needs and MSPSS. And from MSPSS working group itself, we usually have this kind of monthly meeting, but during the COVID-19, starting from May last year, I guess, we started to have like weekly meeting in order to provide the regular update from the global resources and to share some of the useful resources for our members, also to get the full update from our members. We also make some adaptation from global resources in different Myanmar language. This is another positive side from the COVID-19 because, as I mentioned earlier, that the lack of awareness in terms of mental health and psychosocial support. But due to COVID-19, the involvement of community, humanitarian actors, including government in MSPSS is increasing. It shows by the improving number of the visitor, because we have MSPSS working group website, which is like the resource that we use to publish a material specifically for the reference group. So within the last 3 months, the number of new visitors is like increasing more than 50%. And mostly they visited the referral directory pages in order to access in which location, because under our referral directory, they have like based on the state. So it's like increasing. I will show in the next presentation. Also increasing the number of partners who requested to get MSPSS training to respond the community needs. So the global resources that we have is really useful from our side in order to respond the needs of our members. So this is like the quick from the youth initiative by UNFPA. So from here we can see like the challenge faced by the young people. Mostly they have some concern related to health, employment, and education. And here from the one of the surveys, like conducted more than 6,000 reporters. Again, it is mostly for the young people, 62% female and around 30% male. From here, we can see like there is more than 70%, around 75%, they express the challenge in terms of mental health psychosocial support. However, from the access here, we can see like more than 70% from them, they don't know how to access or where to get the MSPSS services. So this is like the challenging situation that we are facing here. Here it come like how the reference group product have been used for the basic MSPSS support. Regularly, we share the resource from the reference group to our website and mailing list, also mentioned during the meeting. From that, our members express their willingness to adapt and translate our resources. The example here at basic psychosocial support, we already translated in 5 different local language in Myanmar by UNFPA and IOM. This module is very helpful, as Dr. Kamil mentioned earlier, like MSPSS worker, skill, because it's kind of like very practical guidelines, right? From here, like especially with the context, we have limited mental health professional self-care, so for creating this resources for.
We're losing you a little bit, Adib. I wonder if maybe turning.
Internet
Yes.
connection here now. Can you get me back?
We can hear you better a bit now.
Okay.
Maybe the camera can help, but as you see.
Yeah, so this is actions that we use.
I'm afraid, colleagues, I'm afraid we've lost the connection of Adib. Is the difficulty of joining this session from very unstable internet connections. We will try to get him back, and hopefully he can join us again. This is where our colleagues are working in not so easy circumstances and with difficult connection.
Yes, I am so sorry.
Oh, here you are. Wonderful.
Yeah, thank you. So sorry for the connection. So this is will be my last presentation. So I will just mention like this is the current situation. This will be usually happen in regards to the current situation that we have here as the COVID-19. When our partner mostly they get used to with the MSPSS remote services, and with the current situation mostly we got the internet until, let's say, 10 or 11 p.m. and then we get the internet back in the morning around in the morning. So it's like the current challenging that we currently facing. So this is the additional challenge that we are currently facing. So that's quickly from my side. I hope that I will not take more time. So I'll get back to Dr. Chairman.
Not at all.
Thank you, Adib. Thank you.
Thank you so much, Adib. That was extremely useful. And yeah, we can imagine now that the entire world talks about online services because we can't see people because of COVID. But sometimes online is not even an option. So it's very important for all of us to remember that the circumstances are very different in very different places. So thank you once more for joining us, and thank you, Internet, for holding in there a little bit. I might get back to our colleagues with another question from my side later on, but first of all, I would like to see if there are questions either that have already been asked in the chat, or if anybody else would like to raise their hands and make any further questions to either Fahmi, myself, or any of our colleagues from country level. Please do so. Feel free to raise your hand. I can very quickly say to Concheta, yes, we will be sharing both the recording and the presentations with all of the registered participants. Sarah, yes, over to you.
Yes, thank you, Carmen. There's a question from Gabrielle in the chat, which is actually more to do with the data, actually. And in response to your earlier slides where there was showing the huge surge in services provided for MHPSS support, but the question is looking at kind of documentation on number of people supported in the different contexts of countries, if that's been tracked somewhere. And if available, if there's any examples of evaluations for interventions that might have happened in response to COVID.
Thank you so much for that question. Fahmi, do you want me to get that question, or would you like to?
I think it's a very important question. The field of mental health and the field of mental health and development settings outside humanitarian settings classically has suffered from limited data available. If you look at the mental health action plan, one of the indicators which is really behind is the indicator on countries reporting on set of core mental health indicators. 33% of the countries in the baseline last year were able to report out of 80% the desired. 33% of countries of the world are able to report on core set of mental health indicators. Sadly, that's one of the weakest links we have in the area of mental health. So WHO has assessed between June and August last year the continuation or the disruption in mental health services in a report. I'll happy to share with you. It's linked here. This survey is planned every 6 months and it's done again. So it was done between January and March this year, and results will be released soon. Sadly, we saw 93% of services disrupted. In the next survey in June, between June and March, we saw that this is around 30 something of the service disrupted, but still the services for the most vulnerable groups are the most badly affected, such as services for older adults, services for children, and emergency mental health services badly disrupted. However, we see growth around the world in coordination mechanism and integration in policy and plans and allocating resources for mental health and psychosocial support. The new thing which is happening in 2 weeks from now is that for the first time, the Global Mental Health Action Plan that countries will be deciding and voting on and during the World Health Assembly would have indicators on mental health and psychosocial support, including country preparedness for mental health and psychosocial support, including for public health emergencies. And let me update you that the IASC Reference Group is also updating a full monitoring and evaluation framework that will be released this year, which will include also data collection tools that will allow us all to measure collective impact of the work we do in countries for the first time ever.
Thank you so much, Fahmi. I'm glad that you mentioned the framework, because we're so happy that we have this resource for organizations globally to harmonize how we measure our impact. This is going to be really important. Are there any other questions or comments from the audience?
If I can just say, the other questions were some discussion on how the basic psychosocial skill guides has been used or adapted in countries, which I think some of the panelists referred to in their presentations.
Yes, indeed,
well.
and I think we noticing that it's very useful. It happened also when Psychological First Aid was published many years ago already. These kind of resources where anybody in the community can receive enough skills training to know what to do, to comfort somebody, to address somebody who's going through distress because of the situation, to use communication skills that tend to be so useful that we have a lot of requests for the use. Obviously, in the current circumstances, a lot of what is being done is online. We've been able to reach many through online trainings or webinars, etc. Very recently, I've been working with Venezuela Child Protection Area Responsibility, for example, to train them online in this resource. And we keep on working, we keep on receiving requests for adaptations and for online training. There's also, I'll try to find the link in a minute, but there's also, for example, a really beautiful exercise done by this Sri Lanka community, MHPSS community, to create a portal for basic psychosocial skills training, which includes videos and exercises, both in local language and in English. So more and more is being taken off, and the information is again to be found in our website, and you can always contact us for more information. We're really happy that this has been useful for our colleagues. I can see more things popping. Let me see.
There's a question from Yeni asking how are country-level technical working groups, this is perhaps to the panelists, to Adib, Deborah and Nikos, how are your technical working groups addressing the duty of care? And particularly because for first responders, so people directly providing services in relation to COVID. So also including things like staff well-being or staff care and volunteer well-being.
Very important. Is any Adib or Deborah, you mentioned Deborah a little bit on this, or Nikos, any of you would like to respond? Yes, Deborah, go ahead.
Yes, maybe I can share with, because I also mentioning, our priority before is focusing on the implementation of our MHPSS program during those COVID-19. But I think the most priority is actually the staff and also the well-being of the staff. And we admitted that it was a really huge impact on the staff. And we understand how it was difficult for even the staff to do their job and carrying their intervention directly, because there is a lot of restriction, lockdown, and etc. And also their fear. They're also afraid of getting infected by the COVID-19 because of this confusion and also all the information coming, especially in the beginning. So what we do and still continue actually with the staff care, because we have a lot of requests coming through the MHPSS working group. There's not many staff counselor within the organizations. It's only few. Even within the UN agencies, maybe only 1 or 2 UN agencies have dedicated staff counselors. In the international organizations or even in the national organization of civil society, it was more difficult. So what we did at that time, we shared information asking the counselors, is there any available of clinical psychologists, psychiatrists, and also psychiatric nurse? We put it into like a pool of counselors that are available to do a remote counseling for the staff. So we have those pool, or we have the pool of staff coming from, I think it was more than 25 organizations at that time. But of course, we selected based on their level of competency and also experiences. So we have a grade A, B, C to attend to specific cases. So this is what we did and try to do and continuously up to now. It was not easy, of course. Maybe Myanmar experiencing about the issue on the internet connection, we also experiences more or less the same, especially to those in the hard to reach area. But at least we have available resources. Not that I'm not saying it was ideal, but that's the thing that we really try to do, because we admit that there's a really huge impact to the staff care at that period of time, and of course up to now. Thank you so much, Carmen. Over to you, and maybe Adip or Nikos can add. Thank you.
Indeed, thank you so much for that answer. Adip or Nikos, any addition to that? Adip, yes.
If I may add, just quickly at what Deborah already mentioned. Actually, before COVID-19, one of the priority for MSPSS working group is like we would focus more on the self-care. And then by accident, this 2020 is like unpredicted that COVID-19 happened. So it's already there. So at least one of the working group members, including ACF and some other members, they already have the modules that they're implementing. So this year, finally, we have this kind of lesson learned from them, how they implement the self-care for the staff and specifically for us first line responder. So it is really useful, and including a part of the regular working group meeting, they are voluntarily to provide this kind of quick session. Let's say they spend 10-15 minutes in order to how to do it. For example, mindfulness practices or this kind of thing that we currently apply a part of the MSPSS working group meeting. So I hope this is also add some of the information. Thank you. Over to you, Dr. Chairman.
Thank you so much. I'm going to very quickly check with Nikos if he has any addition to this point. Otherwise, I'll go to Fahmi. Nikos.
Yeah.
Yes.
What I would like to say is that it's a really complex issue, this one, and it's not easy to reply to a question. It's more to comment on different factors that affect what happens and what we can do. What is given for sure is that after the outbreak, quite all agencies, organizations took measures for the protection, first of all, of the staff, so that the staff could continue offering their support. And these measures were also guided, if you like, by guidance given also by the Ministry of Health. For example, remote and telework and such things. But from the other hand, it was very important for us, as I said, how us to feel strong enough and equipped enough in order to continue delivering services. And this is what we did as MHPSS Technical Working Group. For example, we created a subgroup with colleagues who were working remotely to study upon this, to exchange among them experiences, good practices, because for many of us to work remotely was something new. And it was very important to feel that we can do it and to exchange with others, to search the references, the bibliography, and for example, the Who-Equip project was very, very useful for us and helpful. Sorry. From the other hand, we had to show how it is to underline and to advocate for measures that should be taken for people that we work for. For example, refugees living in camps. There were many problems that were very, and still are, there are very serious problems with these people, that they are confined in the camps, and many of them cannot, cannot take the measures that are appropriate to protect themselves because of overcrowded camps, because of the lack of basic needs and so on. So we still need to always advocate about this. Another issue that is very serious now, especially for refugee kids, is that since in the country, in Greece, all pupils go to school, do not go to school anymore, but they follow remotely, it is a challenge how refugee children can also follow lessons remotely. This is not easy, or it is obstacle for them. So we have to advocate for them in order to be able to do things. And the same is for vaccines and so on.
Mm-hmm. Thank you so much, Nico.
So many different fields in which we need to work, because each one has its own difficulties, challenges, and particularities, let's say. Thank you.
Indeed, indeed. Thank you so much, and thank you for the reminder of how complex and how many layers there are to this response. I'm very aware of time, but I would really like to go over to Fahmi. Maybe you can. I was looking in the chat. There's a comment on DRR, and I would like to go to you and take your point on this.
Thank you so much, Carmen. I'm not going to add more on the topic of staff care, because it was a question mainly to technical working groups. But I want to take this opportunity to thank Yanni and Renette and colleagues from the Ministry of Foreign Affairs of the Netherlands, because we explained the context where MHPSS has grown in 2020, but that came really thanks to decades of work of many colleagues, but particularly to the Netherlands for their strong advocacy during 2019, during the Amsterdam conference, and the following months and years to put MHPSS high on the humanitarian policy and response agenda. So really, we are grateful for their strong advocacy and work. And I want to respond to Natalia, who highlighted the very important point about the disaster risk reduction. And in fact, we released during COVID-19 a document on links between DRR and MHPSS, and it's more important now than ever, because we should not think of COVID-19 only as an opportunity to integrate mental health and psychosocial support in response. We need to think about preparedness, which is commonly neglected, unfortunately, in mental health and psychosocial support area, in countries' preparedness, and also in recovery, using COVID-19 as an opportunity to build better social and mental health care systems and mental health and psychosocial supports integrated into different sectors. So the DRR document with its monitoring indicators, I think, Natalia, I shared in the chat function hierarchy, and still we need to do more to integrate with DRR, disaster risk reduction, as a field. I want to say, from all the tools we saw today, colleagues from countries working with UNFPA, with IOM, you are linked with IFRC, I'm linked and working with WHO. Carmen, we heard about Babel, which is also an NGO in Greece. All of us are talking about tools we developed together. One of the uniqueness about these tools is that it has the IASC logo. These tools are seen neutral in the field and used by everyone. So I think that was key in developing these resources, and make us all, rarely one of our agencies would develop a tool specifically during the COVID response. Most of us use the tool that we developed together with IASC. So really the MHPSS community came together during the COVID-19 and developed these resources early in the response. Again, another unique issue in these resources is that all of them were developed through communication with the affected population. So we talked with COVID-19 responders, with children, we talked with frontline responders, with older adults to develop these resources. We listened to the field. We did not develop it while we are sitting either in Copenhagen or Geneva or different HQs. I think this were key for success. And then the dissemination. Dissemination was not, again, done by any organization at HQ. Dissemination was done by good uptake from countries, because countries had ownership, because they were engaged in developing these resources. Thanks everyone for listening, and back to you, Carmen.
Thank you so much, Fahmi, for those remarks, and nothing else from our side. I want to say a very big thank you to Nikos, to Adib, and for Deborah for making time in your very busy days to join us today and share your work. Thank you, everybody, for joining us and for being with us today. And two taking home points. One, COVID-19 is highlighting definitely what MHPSS relevance is. We have to continue working on MHPSS. This is an opportunity. We see it as an opportunity. Second point, when we come together, when we work as a joint force, we produce wonderful things that can be of use for the communities. So with those 2 points, we thank you all very much. We encourage those who are not maybe MHPSS related participants, please keep on following through the reference group, and let's all continue providing more mental health and well-being for all communities affected worldwide. Have a lovely rest of the day and hope to see you around. Thank you.